Hey everybody, this is Leslie, and I'm interviewing my dad, Dan Yan. He's a PA about MI. So, Danny, can you explain a little bit about the pathophysiology?
Well, myocardial infarction is a heart attack, and that means that there's been death of heart muscle. Generally, what the cause is a blockage in one of the coronary arteries. Blockages are generally caused by cholesterol buildup and white blood cells, calcium, things like that that narrow the artery. Usually, a heart attack is when there's a rupture of that plaque into the artery, which then causes a blood clot to form.
And what are some clinical manifestations or signs and symptoms that you have seen patients present with?
Well, the most common and sort of textbook one is chest pain. It's substernal left sided chest pain, radiates to the arm or the jaw. Additionally, patients will have shortness of breath, nausea, sweats, things like that. Um, Occasionally, you'll see some other manifestations that may not necessarily have the chest pain, just have the shoulder pain, may have pain behind their between their shoulders or in the epigastric area.
What is the craziest signs and symptoms you've seen a patient present with that had an MI?
Patient who had left ear pain. He was a lifeguard, and it was initially felt to be something like swimmer's ear, but when they did an electrocardiogram, he was actually having a large anterior wall MI.
And can you list any associated risk factors?
Well, the common ones that you're gonna run into, they say male gender. However, women are rapidly catching up to that. Certainly, hypertension, cholesterol problems, smoking, genetics, things like that are also well known.
Thank you. And what are some specific lab or diagnostic tests y'all do to treat?
Well, the main one that we use is the electrocardiogram. That should be done within once the patient arrives at the emergency room and interpreted within really just several minutes. Additional labs that we would use would include the cardiac enzymes, the troponin or the CKMB, which those are caused by death of the heart tissue, causing release of the enzyme into the bloodstream. And then additionally, we can use echocardiograms to look to see if there are wall motion abnormalities or congestive heart failure. And then lastly, you would do a heart catheterization.
Thank you. And how does the troponin normally work? Because I know that you retest that.
Well, you got to go back and think about what happens with enzymes. The heart tissue dies, the cells rupture, and then there's release of the enzyme. This takes time. Troponin itself, usually, depending upon which assay it is, rises between 2 and 4 hours. So the patient coming in with a half hour chest pain, you're not going to see a rise in that. So you're going to do serial troponins to evaluate if there has been damage. You can continue to watch the enzymes further to kind of ascertain when the peak is and how high the peak was to give one idea of how large the infarct may have been.
Thank you. And pharmacological intervention as well as nursing implications.
Well, your standard pharmacological intervention is any patient with chest pain. You're going to start with aspirin, nitrates, oxygen, and morphine. As you know that this is an infarct, you're going to add beta blockers as well as blood thinners like IV heparin, antiplatelet agents. You've already talked about aspirin, but there's also Plavix and those antiplatelet agents. And then if the patient, if it's not a situation where cardiac cath and angioplasty is appropriate, you may consider thrombolytic therapy. And then once the patient is discharged, in addition to being on an aspirin and beta blocker, they should be on an ACE inhibitor or an ARB as well as a statin.
And collaborative care based on evidence based practices.
Well, again, kind of depends on which type of infarct you're talking about, a non-AC7 elevation myocardial infarction, sometimes can be treated medically. However, usually they eventually get to the cath lab so that we can look to see if percutaneous intervention is appropriate or if they may need bypass. Certainly, a STEMI coming into the emergency room needs early reperfusion therapy, whether that be thrombolytic therapy or primary intervention. And then ultimately, some patients have significant disease that coronary bypass graft surgery is appropriate.
And cardiac rehab, is that listed as also?
Yes, cardiac rehab, which works with educating the patient, helping them with risk factor management, including usually dietary management, smoking cessation, as well as they generally get put into an exercise program, which both helps to retrain the heart as well as develop them into something they can continue to practice, again, with the idea of decreasing their risk factors.
And last thing, any associated complications?
Well, death certainly, and this can be from pump failure, heart rupture, or cardiac arrhythmia. And all of those are also attendant complications because they can develop congestive heart failure, cardiogenic shock. Also, you worry about respiratory failure, kidney failure, and the like.
And lastly, what is the most memorable experience you've had with a patient experiencing an MI?
On a Saturday, a mid 40s gentleman who was quite a distance from the hospital was brought in by rescue with an acute inferior wall myocardial infarction. He went into ventricular tachycardia essentially at the back door, and we had a stuttering resuscitation for 45 minutes to an hour before finally getting him to the cath lab. The thing with this particular case was, though a couple of times he did lose consciousness, most of the time he was in just an unstable ventricular tachycardia. So there were several times when he would get shocked when he was wide awake.
And you called that a stuttering resuscitation?
There were periods where we had a normal rhythm and he was free from arrhythmia. But as one example, is we were finally ready to go to the cath lab and had him out of the trauma bay into the ER proper. When he went into VTAC again, we had to like back up into the trauma bay and continue with that until he finally was stable enough on antiarrhythmic medications to get to the cath lab, where he did have a successful stent placed to his right coronary.
And what makes that so memorable?
I think mostly because it was a challenging case from the very beginning. It's one thing to have a patient who arrests in the setting of an MI and you shock them once or twice and get ROSC, at which point they're stabilized enough to get the cath lab. This was just one that just kind of kept going on. And the interesting part of it is when I or the cardiologist that was with me would yell clear to defibrillate him, he'd be yelling, no, 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 not clear.
And is this the same patient that ended up writing a book?
Yes, he wrote a book about his experiences called Nine Words in Heaven, which actually had to do more with an out-of-body experience he occurred during the resuscitation. But he actually does describe a patient's experience very well. And I have to be honest, when I read it, I felt it was kind of surreal to be reading about events that I took part in and seeing it from somebody else's perspective.
That's awesome. Well, thank you so much. Is there anything you'd like to add about MI?
No, except to say that I've been in cardiology for greater than 30 years, and the advancements that I've seen in my career have been phenomenal. When I first started, angioplasty just balloon had just started, and no one would have ever thought then to take somebody directly to the cath lab.
Well, thank you so much.
You're welcome.